All right, thanks for having me, guys. So Dr. Umbright, urologic oncology, so kind of all the cancers that we do in urology. I'm on the Air Force side. In the Air Force, we only have one of me. So this is the only place that we are. So if any of you want to take my job for my residence, I have to retire or die. But that's a backstory. But anyways, the Army side, there are like 4 or 6. I think there's 4 right now spots, so it's a little bit looser. But initially, Lydia reached out to me and just said, "Hey, give us a talk on urology, cancer," which is like, well, I've spent 7 years doing that, so I don't know how to deduce that down for you guys in an hour. So I really basically just try to figure out some place that we overlap. Because like me giving you a complex talk on bladder cancer is like you giving me a talk on thyroid. Like I get the principles, but it's not very educational for me. So I feel like in adrenal, we overlap a lot. So the 2 institutions I trained at, Mayo Clinic in Minnesota and then MD Anderson in Houston, like urology was really involved with adrenal versus I think here you guys primarily do the adrenal. Like I haven't seen anything really unless it just randomly ends up in my clinic. So maybe this is a good place where like my training kind of can actually help you guys go forward. And I heard that you wanted me to talk about hydroceles. So if the scrotum's enlarged, transilluminate it. And if it doesn't transilluminate, get an ultrasound. If it does transilluminate, call a urologist to help you do it. I don't know. The hydroceles are boring. So, but that's like the one slide on hydroceles. All right. So adrenal incidentalomas. When I was in training, this was like always so confusing to me. I had a ton of different staff that like worked it up different ways. And then adrenocortical carcinoma, like basically I felt like it was all over the board. So I really figured out a way, I think in my mind to make this stuff really logical and straightforward. And that's what I'm going to share with you today. There's guidelines out there, but if you look at guidelines for any of this stuff, what you'll see is there's like 7 guidelines for each and they differ in little ways. So there's no real authority in this space, I think is an important part of the discussion. So you guys have to figure out how you want to organize your thoughts when it comes to adrenal workups. This is how I do it. This is kind of like a combination of the way that I was trained to do it, plus looking at some of the guidelines. You guys can take what you want from it. So we'll review a little bit of the epidemiology and presentation of adrenal incidentalomas, and then talk about adrenocortical carcinoma, ACC. It's a really rare tumor, but it's one that we have to get right when we see it. So it's important to at least have a framework to consider it. So the assessment of the AI and then the overview and treatment approach to our localized adrenocortical carcinoma. I think the big thing about, I kept it to localized because there's so much going on in the metastatic and advanced space that it's just hard to condense that. And honestly, at that point, you guys are like us, like off you go to medical oncology, right? Like on some level, your work is done after the surgical part. So, but there are some stuff, there is some space in there if you guys want to talk about it that I think we play a role. So just illustrative case. 60-year-old female comes to you. She's got this history of non-small cell lung carcinoma. She's got a history of ovarian carcinoma. You get this CT scan. I'm not going to let you flip through the scans. But what are you guys thinking right away? What's your thought?
Like the upper range for concerning the
Yeah, maybe.
History of cancer, concerning brain.
She got this history of cancer. That low, the high Hounsfield unit is a tip off to something. Was it more of a tip off towards that real low? Adenoma, yeah. So yeah, she has this history, but it's probably adenoma just based on the Hounsfield units alone. So again, this is part of like, hey, when I see things like, how do we kind of work these patients up? How do we go forward? So I call them phenotypes. Her radiographic phenotype basically shows us, you know, this is more likely adenoma. We're going to do more work to figure that out, but that's what we're probably looking at there. So adrenal masses found incidentally. You know, if you just take all these population studies that are out there now, it looks like it used to be people said 0.5%, and now the more recent SEER data says about 10% of patients that randomly get scanned are going to have incidental adrenal masses. So this is something we're going to see more and more and more. Of course, like I said, increasing with the proliferation of abdominal imaging. So, you know, you get checked into the ER, you go through the donut, you get admitted. So it's like we're getting these consults more and more and more. Subclinical adrenal hormone excess is a really interesting kind of space we're not going to get into too much, but basically patients a lot of times don't really realize they have hormone abnormalities coming from adrenal adenomas. So it's really important for us to screen for them because it really does increase their risks of problems like cardiovascular disease or mortality, especially cortisol, so subclinical Cushing's. And then primary adrenal malignancies are definitely rare, but we don't want to miss them. So I know of at least one case where someone missed it and it ended up being a huge medical legal issue for them. It was also on my board. So for us, that was like on my boards, like the workup of this, and I had to do appropriate follow-up. And when I got them in follow-up, they had like ACC that had spread to the lymph nodes. So I had to like go through that whole algorithm. So it'd be important for that part too. So I don't want to belabor this point, but differential diagnosis for adrenal masses. Really, it's kind of benign versus malignant, but then functional versus non-functional. Most of you guys probably know this stuff, but essentially the benign things are mostly adenomas. And then there's these other kind of crazy things that can happen like paragangliomas, hemorrhage, cyst, infections. And then PHIOs can be malignant or they can be benign. Do you guys remember the old rule for PHIOs? How many are benign versus malignant, and how many are bilateral? There's like this is like it's like 10% for everything kind of thing. And then malignancies, we really worry mostly about the primary malignancies, but of course patients can also get like lymphomas that can start there, sarcomas, which are super rare, but it can start there. And then metastatic disease is the most common malignant thing we're going to find in the adrenal gland. So coming from somewhere else. So this is kind of my little general diagnostic approach. This is how I kind of think about any kind of adrenal mass or any kind of workup going forward. I kind of just group it: clinical, biochemical, radiographic. And what is there evidence for hormone excess, because we need to catch that, and then is there suspicion for malignancy, because those are the two biggest issues. So clinical phenotype, what kind of things do you guys think we would see in hormone excess? We talk about an adrenal. Cushing, so Cushing's stuff, what does that look like when they have high cortisol?
They're gonna have like moon faces.
The moon faces, yeah. Yep. Yep, good. Yeah, those are the big hitters for Cushing's. And it's usually pronounced, like when they have really bad Cushing's syndrome, that you'll really see it. It's really pronounced. They'll be like completely in shape, like 22-year-old person that's like all of a sudden they're 23 and they're like, I just ballooned up into this beach ball. So it's really impressive when you see it. And then the virilization, you always want to ask about virilization or look for it. So women that are growing hair where they don't want it, or men that are getting gynecomastia. So those are, again, clinical phenotypes that you're looking for. So biochemical phenotypes, so we'll get into that. So that's going to be like, hey, how do we assess and screen for hormone excess? And then radiographic phenotype, how do we kind of help ourselves figure out what it is just radiographically? There are nuance to all of this that I'm not going to get into. So if there's something you're like, hey, I've heard, or I have a question about, just stop me, and we'll get through that. So clinical phenotype, these are kind of the big three I try to press on. So cortical excess, catecholamine excess, and aldosterone excess. And then I already said virilization is one that you kind of screen for mentally really quickly. But the most common one we see is a cortical excess. You guys remember Cushing's syndrome versus Cushing's disease? That whole, you guys, so what's Cushing's disease? Starts in the pituitary, right? And then Cushing's syndrome is just any excess, essentially. So, but really the big thing is going to be obesity, weight change, the things she mentioned earlier. And it really it leads to a lot of risks for cardiovascular and endothelial dysfunction. So we got to catch it. Catecholamine excess is usually pretty obvious, PHIO. What's not as obvious about PHIO is that a lot of times it'll present with younger people that have episodic episodes. And so we tend to like try to poo-poo it because we're like, well, they're not always tachy. They don't always have hypertensive emergencies. Like it really is like that. They have like kind of this ebb and flow. So they'll usually come in and being like, man, sometimes my heart just races for like 45 minutes and I don't know why. But then for 3 weeks, I'm good, you know? So that's like the typical PHIO excess. It's not a consistent thing. Usually they actually come through cards. A lot of them will come through cards because their primary care will send them cards for arrhythmias or palpitations. And then aldosterone excess is one that is so rare to have Cohen syndrome, but basically hypertension, hypokalemia, stroke, those kind of things. But really, everyone has hypertension, so we just really miss this unless we're looking for it. So Cushing's syndrome, you guys have already mentioned these, the typical look. So the striae, you can see those in the calves. You can also, this is typically how you see them. Easy bruising is another version. The buffalo hump, the red cheeks, moon faces, all those things. So like I said, the beach ball effect, as I like to call it. And then viralization. So there's a female patient on the left and in the middle. Obviously, like that isn't normal for females to have that kind of hair pattern. And then a male patient on the far right with kind of that gynecomastia. So Cole was in clinic with me not that long ago, and we had an adrenal, and he said, well, why aren't you checking for sex hormones? Well, I don't usually check for sex hormones unless I see stuff like this. Okay, so it's not part of my routine screening. So biochemical phenotype is really doing the screening. All right, so I don't know what the general surgery literature says. This is relatively agreed upon in the urology literature, what I'm presenting to you guys. But you guys can at least share with me, I guess, if you say there's something different. So for hypercortisol, we really, every single patient in our literature, they say, hey, you should always check. We typically do it with a 1 milligram dexamethasone suppression test. If you guys aren't familiar, you literally prescribe them 1 milligram of dexamethasone, say, hey, take this at 10 or 11 o'clock tonight or tomorrow, whatever. And then they come in for an 8 a.m. cortisol the next morning. And what you should see is really good suppression. So their cortisol should be low or low normal. And so that 5 cutoff is typically what I use. But if they stay 10, 20, 30 for their cortisol levels, then my dexamethasone didn't do anything. And so I know they have excess cortisol. FeO, I personally check for FeO and primary aldosteronism on everyone. So it's very easy. I figure I'm sending them to the lab anyways. It's just, I get plasma fractionated metanephrine. So a lot of the literature talks about getting it in the urine. I think that's fine for a follow-up test. But I think for primary just screening for FeO, you should just get a plasma fractionated metanephrines. The big thing is that it should be at least 2 times the upper limit of normal for you to get really concerned. So a lot of times you'll get it and it'll be like in the upper range, but it won't be like double the upper range. Those are kind of those funny ones. I actually will go back then and get a 24-hour urine on those patients. If I still can't really figure it out, I send them off to endocrinology because they're a big help in that situation. Primary aldo, I check it on everyone. There's all this literature says if their K is okay, if they don't have hypertension, you don't need to worry. But I'm just like, I'm not a very smart person and I just want to do the same thing on every single person and never miss anything. And so I just do primary aldosteronism screening on everyone. The best way to do that's going to be your serum aldosterone and you just divide it by your plasma renin activity. So that it sounds like it's a funny test and it's fancy, but it's not. You just have to send them to the lab and get both those tests and then you can do the ratio yourself. That ratio should be, my thing is backwards. Your ratio should be less than 20, not greater than 20. So do you guys know there's a couple of medications that really interfere with that ratio? So that interfere with that system. So if I'm seeing a patient and I'm like, hey, I'm going to screen them with their adrenal incidentaloma for primary aldosteronism, what medications am I concerned about? It's going to screw this ratio up for me. So ACE inhibitors and ARBs, correct. So what do those do?
Well, they block angiotensin converting enzyme, right in the middle of that system.
Right. So they're going to increase what artificially? Right. So they're going to artificially lower your ratio. So they're essentially going to artificially say false negative. So it could be a positive, but your angiotensin reception inhibiting is causing them to have a normal ratio. What's the other big one, which is not as obvious, but you guys need to catch? What? No. Well, that's good for that's actually good for virilization issues, but not so much for this. It's another blood pressure medication, typically. So I'll just tell you, beta blockers. Like people don't think about it. So what's weird about beta blockers is they increase your aldosterone, like they just do in everyone. So they're it's an odd drug that way, and they don't actually totally understand, but it increases your aldosterone, so it will give you false positives. So you usually need them off of those medications for a week, and then you can check. So that's something to be aware of. Now, these patients all have hypertension if they have aldosteronism, right? So like they're on these medications, so it's really important to be aware of that. All right, and then adrenal androgen excess. Again, I only do it if I see virilization or funny hair patterns. You should just check for testosterone and DHEAS. You can check for estrogens. There's really no there's no really guideline for that, but their phenotype, their clinical phenotype is so obvious that you usually are going to check. Is this about what you guys do in Gen Surg? Pretty much the exact same. Good, we're getting consistent. All right, and then the last thing, radiographic phenotype. This can get really complex. I'm not going to go into it too much today, but these are what I consider the kind of the big hitters that you guys should be aware of. We use that 4 centimeter cutoff for when to get worried that it could be something more worrisome like an ACC or you know, a pheo that's malignant. That being said, I'll show you some of the data on that. I think the 4 to 6 is where we start to see the transition. So you'll see a lot of people sit on like 4.5, 5 centimeter adrenal things that aren't too worrisome, that look just like adenoma or non-functional adenoma. Hounsfield units are really important in unenhanced. So less than 10, you can kind of feel pretty good about things. Greater than 10, you need to continue to kind of do a workup. Washouts. So you guys, ever notice you go to CT scan, you'll see like adrenal, like there's a specific scan. It's so that they can get these washouts, which we'll talk about a little bit. But these washouts are kind of how fast is the contrast clear. And so if it's really fast, that's usually adenoma. If it's slowed or kind of, more heterogeneous, then that's going to be worrisome for malignancy. I think the other ones that are worth noting, FDG activity, yes, we see it in malignancies. We tend to not see it in adenoma. I think that's important because that's, again, people get these PET scans and then they're like, oh, look, the adrenal lit up. What do you think? So there's like a common curbside. Irregular borders is like silly to me, but whatever, it's in here. Homogeneous, adenomas tend to be really homogeneous. So if they have like funny kind of different areas and look like there's tumor heterogeneity, you should be a little bit more concerned. Central necrosis is hard to tell the difference between that and a cyst, but you should at least be looking. And calcifications, this is a funny space. So if the tumor has like calcifications in it, this is one of the few tumors that actually points more towards it being a problem. It's usually a lot of our tumors, that's kind of more of a benign finding. Now, if the whole adrenal gland is calcified, that's a totally different thing. But inside a tumor, if you see calcifications, and then rate of growth during surveillance. So this gets quoted everywhere. I can't find any literature to support rate of growth. So I don't know if maybe you guys can correct me if I'm wrong, but I can't find it anywhere that said, if it grows fast, take it out. We're surgeons. We like to cut things out of people. All right. Questions or concerns on this stuff? So tumor size and risk of malignancy. So we'll go back to some of that stuff from the phenotyping. So if you take all comers, and this slide's a little messy, but this big blue thing is adenoma. So this is my mostly benign group. So 2 to 4, the vast majority of what I'm looking at in that space is adenomas. And then the other thing that I'm looking at is this gray box on top. That's metastases from other tumors. So as you can, I'll go back. Sorry about that. So as you can tell, these 2 to 4 centimeters, like if they don't have a risk of malignancy in the past, they don't presently have one, the vast majority of these patients are adenomas, and you can kind of just watch them, make sure they're not functional, and then go from there. As soon as we get into this 4 to 6 range, you see that adenoma really shrink up. And so you start to worry that you're not just looking at adenomas, and then your pheo, which is this orange one, pheos become a lot more prevalent in this space. And then your adrenal cancers, which I think is an important part, is these guys. So these yellow guys start to actually come into play now. And then when we get above 6, that yellow box gets real big. So we get above 6, we really do start to worry about primary adrenal cancers. Our metastatic rates are the same. Our adenoma rates go down. So this is basically where that's coming from. So you guys see the 4 centimeter and 6 centimeter cutoffs. It's really from this where we're starting to see those adenomas really come down, and you got to be paying a little bit more attention. Okay, which means most adenomas don't grow to be these sizes, which is, I think, what you should think too. So CT washout, when I was in residency and in training, I've always been like 50% is the washout, but there's actually two. There's an absolute and a relative washout. Your radiologist should do this for you. But essentially, if it's washing out faster than 50% and they don't say, hey, that's good or bad, just use that as your rule. Like if it's greater than 50%, it's likely adenoma. So it's washing out fast. If it's slow, it'll be like 20, 25%. A lot of times you'll see ACCs literally are like 15, 20%. They're really low. So that contrast really hangs in them. And so this is a really great way. If you're like, I can't really tell, I want to get an adrenal CT specifically, it's this washout that you're trying to do. So this is great for your 4 to 6s, right? Your guys that are in that 4 to 6 range, you're like, I don't really know what to do. They don't have a metastatic history or a disease history of the past. I'm not going to just biopsy it, which I don't biopsy adrenal masses routinely. And so this is a really great thing because it comes back a washout of 70%. You're like, bam, I don't have to do anything. You know, now if you're bored and your surgical practice is slow, you can still justify taking it out. But at the same time, if you're busy, you can not. Once you get over 4 centimeters, you can kind of say, hey, we can justify it. But this helps you kind of figure out who's who, especially on that 88-year-old lady that you're seeing that you really don't want to operate on. So when I was at Eglin Air Force Base before this, we actually had a lady. She was like 91. She had a 4.5 centimeter tumor in her adrenal gland, and she washed out like right at 50%. So we were like, okay, we're going to watch her. Come back in 6 months. So she comes back in 2 years, and it was like 20 centimeters and had spread everywhere. So you hate to miss those patients, but it still happens in older people, I think is an important part. Now, you know, they were very distraught and felt like we missed everything back in the day, but we didn't. But the family, even at 90 years old, was like very distraught about this. So again, just get the washouts, try to do the little things to confirm for yourself. I just put this up here for the cystic adrenal masses, differential diagnosis for cystic adrenal masses, because I think that a lot of times in urology, cystic things are not worrisome. So even our cystic cancers in the kidney don't really hurt anyone. They don't really spread, they don't cause a problem, but honestly, cystic adrenal things, it doesn't help us much. So it can be benign and it can be cancer. So cysts don't like push me one way or the other. And I think that's an important thing. If they've had a history of adrenal hemorrhage and now have a cyst, that's probably benign. That makes me less worried. But if they just have cystic stuff and it's the first time I'm seeing it, I definitely can't rely on that to say, hey, I think this is benign. So you got to go through your normal workups. It gets more difficult to evaluate those patients, but you still got to try to do it. And then this I brought up earlier, but differential diagnosis for FDG uptake, because this is, again, we get it for the prostate and the adrenal a lot. You guys probably get it for the adrenal. It can be basically everything. I think that's a hard thing. So you essentially should just start at the beginning and start working it up, try to figure out if it's a malignancy, which is more likely a malignancy than benign if it lights up. The one funny thing, I put the asterisks at the bottom. Sometimes patients that are on mitotane, which we'll get into later, for ACC, their contralateral adrenal gland will light up on FDG. And so sometimes medical oncologists will call you and be like, oh my gosh, you took out the one adrenal gland and they're on mitotane, but now the other adrenal gland is lighting up on PET. First thing you should ask them is, why the hell are you ordering a PET scan? The second thing you should ask them is why they don't know that mitotane causes that. So mitotane will make it look like it's FDG active, which is an important like little side tidbit to know. And maybe a good ABSite like one-timer, you know, or what you still call the ABSite? You know, they ask you the most random questions and you're like, oh, I've heard of this, like, you know. All right, adrenal masses in cancer patients. I think this is actually this is a really cool study. I still go back to it. Yes, it's 1998. I'm dating myself, but it's a good study because it essentially says, hey, if patients already have a cancer or a history of cancer, and you are seeing adrenal masses, what are you worried about? And I think the most important thing is to know is that there's about 10% of these patients will have it. It's usually the tumor that they're dealing with or an adenoma. All right, so you already are like narrowed that down. And really, one patient out of 1,600 patients in this study had ACC. And I think that's an important thing. Like the chance of it being a primary ACC or a new tumor is very, very low. All right, so this is kind of my little flow chart, putting it all together for adrenal incidentalomas. You have an adrenal mass, get your clinical phenotype in clinic. As a urologist, we do very little physical exams, but this is the one place we have to. biochemical phenotype on every single person. So find out if they have hormone excess. Now I've got this whole space over here called confirm hormone excess. This is really like, if it's super obvious from their clinical phenotype and biochemical phenotype, you're pretty good at that point. You can kind of move on to looking at removal or surgery. But if you're really worried about it or it's borderline, get an endocrinologist involved. They're really helpful for this. They even know when to do like venous sampling, which we get quizzed on all the time. And like, I don't know, it seems totally random when they do venous sampling in practice. So, you know, trying to confirm lateralities and stuff like that. So I didn't get into that today because, again, that goes beyond the scope of really our practice and goes into the endocrine space. You should consider surgery for anything that you're worried about for hormone excess. And then radiographic phenotype, you know, for patients that have negative biochemical phenotypes, we're going to look down here, benign. Those Houndfeld units are low, less than 4 centimeters. You know, our washouts are good, all those things. And then more suspicious tumors, you really should just consider surgery if they're larger, you're worried about ACC at all, or metastatic disease. Now, we didn't get into it much because I don't like biopsies on adrenal masses in very many spaces, but the one space is patients that like have a history of breast cancer or uterine cancer or something, and you just are like, I don't think this is ACC. Like, you're really not suspicious for it, and it's important to know. That's the space that you do an adrenal biopsy. Okay. All right, and then surveillance we'll get into in a little bit, like how to survey these people. We can do it now, but basically the follow-up stuff, controversies. So this is the general kind of recommendation: 2 years of imaging, 4 to 5 years of hormonal evaluation. I do it. I think 1 year is probably fine for both. But if you look at the evidence, but I think if it's an ACC or a primary tumor, you're going to catch it in that first year. These things grow relatively quickly. And then if it's non-functional, the chance of it becoming functional is super low. So if you're like, this is a non-functional adenoma, do you really need to follow those? I don't really think so, but that's the current recommendations is to do so. So if you want to keep your license and not get sued, I'd recommend doing it. False positives are a problem. Risk of radiation is a problem. Cost effectiveness, and there's basically none, because we know that less than 1% become functional, and only, 1 in 300 are ACCs that we're missing potentially. Is this kind of what you guys do in terms of follow-up in general surgery? Guy have someone like a 2.5 centimeter mass, hormones are okay, looks like an adenoma. You guys even know? Yeah. Generally. Yeah. I would recommend following them. Again, this was literally on my boards, and I followed her in 6 months, and on my oral boards, this thing blew up. So, like, at least in urology, this is something they expect us to do. All right, so illustrative case, 23. This is a patient I actually took care of, poor lady. So 23-year-old, she was just having tons of weight gain, edema, irregular menses. She was growing hair where she didn't want it. She was having hypertension. She started to get some vague abdominal pain, went to an ER, and they put her in a scanner, and this is what they found. So very large left adrenal mass with tumor thrombus going into the atrium. So like a renal mass, adrenal masses will also make thrombuses and go into the IVC. This is actually a place, like, even where general surgery does a lot of these cases. Sometimes they bring urologists in because we deal with thrombuses more often. But obviously, biochemical profile. This is an active tumor. Cortisol is up. The random cortisol is up. Her urinary cortisol was up. Testosterone was up. So this is a hormonally active tumor concerning for ACC. So incidence of ACC, about 1 case per 1 million. So it is super rare. And this was just updated again in 2018 to confirm that we're still seeing that rate, and we are. So it's been consistent since essentially we've been looking in the 1960s. So it's a super rare tumor. It goes female more than male. Overall, looking at meta-analysis, they say 1.4 to 1. I think it's closer to 2 to 1 when you look at better studies, but I've only had 1 male patient with this, and I can count at least 8 females. So it's just, it's really female dominant in my mind, but the literature doesn't say it's as dominant as I think it is in my experience, which is the problem with our own experiences. And then of course, it has bimodal peaks. So urologists never see it in the first decade. Do you guys get called about like Does pediatric surgery deal with these? Yes.
I suppose they do, but I can't think of a case. There must be some.
You had a bunch, yeah. So it's funny because it's a really like the incidents are really there, you know. So I've never seen it because I think urology is not in that conversation. I think that's peds surgery and surgical oncology.
I just had
Yeah.
a 1-year-old with an ACC last year, actually.
There you go. So super rare.
Yes. Yes, rare, but it does unfortunately
does
happen.
Yeah, so this is a space I don't get pulled into, but I definitely see it on the research that it's a real space. So good. I learned something. It's confirmed. I usually think of the 40-year-old female patient, like that's like my like go-to, but okay. So anyways, these are good. These are like highlights for you guys for ABSITE and stuff like that. Bimodal distribution, female more dominant, pretty rare. So these are the risk factors I mostly want to go into today. Kind of prognostic factors is what I should say, not risk factors. So these are the things that determine how your patient's going to do, and especially when you have localized disease. These are super important things for us as surgeons to be looking at. And so stage is a driver for almost every cancer. So if our staging is correct, it should always drive prognosis. And that's kind of a weird thing that it took me a while to figure out. But like they're always looking at staging and redefining staging based on how people are, how well they do. And so stage should always be one. Ki-67, does anyone know what that is?
It's the it's a coding protein for ribosomal subunits, so it's like a surrogate.
It is that. What is it a surrogate for?
It's a surrogate for like cellular turnover.
Yeah, mitosis. Exactly. So basically think of it as like well differentiated versus poorly differentiated. Things that are turning over more frequently, poorly differentiated, their Ki-67s will be higher. It's honestly just an immunohistologic stain that the pathologists do. There is some expertise necessary. So if you get a patient like this and you're in like, I don't know, Africa, you know, and you're like, oh, I saw this patient and you have one pathologist, you should probably send it to a center of excellence to take a look and make sure that they understand exactly the Ki-67 rates. We'll get into that. Hormone excess matters for prognosis, and then complete resection is absolutely vital. So we'll get into that a lot for us surgeons here. So stage, this is the overall stage, and I've buried kind of the T and M stage within the overall stage, but really stage 1 is T1, which is tumors less than 5 centimeters. So again, that 4 to 6 range that we're talking about, there's actually a prognostic benefit to getting in there before it gets over 5. So we know that stage 1 is better than stage 2. So if you are concerned about an ACC, you would definitely want to get it out earlier than just saying, hey, let's see if this grows. Stage 3 is essentially lymph node positive disease is how you should think about it. So stage 1 is smaller, stage 2 is a little bit bigger, but localized stage 3 is, hey, lymph node positive disease, but also T4 disease, meaning going into the kidney, going into the spleen, something like that. And then stage 4 is essentially metastatic disease is how you should think about it. So it's a little bit more nuanced, but stage 1 and 2 are localized, stage 3 is nodal, stage 4 is metastatic. So in terms of how these patients do on 5-year survival, the stages bear out pretty well. So stage 1 actually do quite well. We don't intervene on very many in stage 1, unfortunately. Like if you look at how many patients we catch in that space, not very many, because it's silent until it's pretty large. So less than 5 centimeters, it's hard for us to catch it. We catch most people stage 2 or 3. We do incredibly worse, obviously, stage by stage in that space. So 50 to 60% long-term survival. And then stage 4 patients just don't do particularly well as most tumors at this point. So major prognostic role of Ki-67. So this slide's a little bit hard maybe for you guys to see, but I just want to point out kind of here. This first came out in 2015, or at least was really validated in 2015. If your Ki-67, so how much was active in the tumor, was less than 10%, then this is this curve. If it's greater than 20%, it's this red curve. And so they saw a massive difference just on mitotic turnover. And so what they did was they was like, well, okay, this is what we're seeing in our population. And they did the best thing they could. They made a validation cohort, which was essentially they went to the Italians, the Germans did, and said, hey, just send all your ACC pathology to us, and we're going to check and see if it validates. And it validated. So patients with high turnover do much worse than patients with low turnover. So this is something that all pathologists should look for if they're not aware of it, you should make them aware of it and then immediately send it to JPC where people are aware of this. Okay, so pathology is a really important thing in cancer. And something I talk about all the time is if people are like, I kind of get it, or I read it out of a book to tell you about this, then you should send it to someone that does this a lot to make sure your path is right. Hormone excess and ACC. These are three major studies that looked at this. And my main point of this slide is to draw your attention to the blue. So the blue is essentially non-functional, meaning no hormone excess in my ACCs. And I always think 50%, but then there's this one study that says no, only a quarter of them. Go back again, sorry. But basically, I won't go back, but basically it's all over the board. Hormone excess is all over the board, but I think you should think about 50% are going to be active, okay? Doesn't matter. I think that's the important thing, if they're functional or non-functional, and it actually does tend to matter. So this is two different studies with looking at hormone overproduction. So the top line is the patients that are non-functional, so the orange line, and the blue dotted line is, hey, these are patients that are functional. And you see there's real consistency across these two studies. There's a minor kind of prognostic indicator here, just mild, that patients with prognosis or do worse prognostically if they have excess hormones. The early thought was that if the Ki-67 was up, that led to more hormone excess, and it was kind of a sign of mitotic activity, but it doesn't bear out. Like, you can separate them and they don't matter. So now, as we've gotten a lot more savvy on cortisol excess and immunotherapies and all those things, I think the going theory now is, this is a cortisol issue that essentially is causing immunosuppression, so our immune systems aren't working as well as they should. All right. So, and this is just kind of a summary of those things. What kind of hurts patients: cancer morbidity, stage, mitotic activity, epigenetic pressures I did not get into, but I don't know how much you guys talk about oncology in here at that level, but basically there's tumor mutational burden. So some tumors have tons of DNA damage and tons of bad genes essentially. ACC doesn't. ACC tends to actually be relatively normal to germline or the rest of your DNA. There's a lot of methylation issues and what we call epigenetic changes, microRNA changes. So it tends to be driven by probably cancer stem cell, but we won't get into that obviously, but that's what I meant by epigenetic pressure. And then on the hormone excess morbidity, metabolic issues, musculoskeletal, cardiovascular. So these patients die from other reasons too that shorten their lives. So potential, I'm not going to get into this. Basically, look, if they have ACC and they have hormone excess, there's a ton of medications we can use to try to control that and make them better surgical candidates, because sometimes they're pretty poor candidates when we first see them. You should call an endocrinologist, okay? But there's a ton of medications out there I'm not going to get into today. All right, management of localized ACC. So we know the prognostic factors: stage, mitotic activity, hormone excess, and complete resection, which is what we're going to talk about for this part. So this is what we're faced with the most. Is managing these kind of things. 55-year-old woman, she's got Cushing's syndrome. She's got this mass, 6.5 centimeter left adrenal mass. Does that look friendly to you or not friendly? What makes you think not friendly? Everything. Heterogeneity, is that what I heard? Yeah. Size, heterogeneity. Those little calcifications in there. Yeah. So yeah, this thing, it doesn't pass the eyeball test, right? This hits so many radiographic hitters for us. So yes, this is something we'd worry about being an ACC. You don't need to stick a needle in it to prove it. ACC really likes to spread easily. It will go along needle tracks, so don't biopsy unless you really have to. So management, we'll talk about preoperative management. Getting that hormone excess in control is important. So if they have FeO components, what do you guys got to do for FeO? If they have tons of catecholamines, how do you deal with that? What's that? Alpha blockade. Okay. And then how long do you have them on alpha blockade before surgery? Until they're orthostatic? Is that what it is? Well, okay. Yeah, 1 to 2 weeks is typically recommended. Urology, I don't know why we're trained to do this, but we usually with an add beta blocker. So we'll block both sides. And so yeah, that's a big part of FEO. There are things that we can do for cortisol to kind of back off that response. Some of those medications I showed you earlier. Work with your endocrinologist and get that stuff under control the best you can going in. Your endocrinologist will usually walk you through the FEO stuff too, which is kind of nice. Surgical management, if it is FEO, there's two big things that we talk about in urology for FEO. What do you want to tell your anesthesiologist about your IV fluids? It's part of team steps. So if you got a FEO in team steps, I would expect my residents to do this, is tell them something about IV fluids for this case.
They're going to need a lot.
They're going to need a lot. And why are they going to need a lot?
Because once you lose that strong sympathetic drive, they're going to kind of have a vasodilatory effect.
Yeah.
And you're just going to have to fill the tank.
Exactly. So they're going to try to bottom out their pressure. So you basically fill them early, fill them fast, and be ready for a big tank. So when does that happen? When does that pressure just drop off? You said when we get rid of the catecholamines, but what part of the surgery is that? You clamp the vein, right? Do you do that early or late in the surgery? Early. So in urology, the way we're taught, we literally go for that vein first. That's like how we start the operation. So we just, as soon as we get to that space, we're going to take the adrenal vein as soon as possible, just so that we can get an idea of how they're going to respond. We're going to bolus the crap out of them, let them do it. Now, if you've done proper alpha and beta blockade, my experiences, the anesthesiologist doesn't really notice. But this is a case that you may want to have a trained anesthesiologist and not a CRNA that is used to just doing 7 outpatient procedures every day. So this is one of those spaces where you want to have the right people helping you. Okay. I know that's maybe rude, but it is a real thing. So some of the larger cases I do, that's something I definitely think about. And FEOs can be small cases and done laparoscopically, and you still want to think about it. Okay. Okay, surgical management we'll talk about. So surgical management, laparoscopic versus open, a little bit of a controversial space, but what do you guys think? Open, yeah. So it's recommended to do it open. I know there are people that can do it laparoscopically out there and can do a really good job, but universally open is the standard. Lymphadenectomy, we're going to do a lymphadenectomy. This is always a question in cancer surgery, right? Do we take nodes or not? Is it helpful? Yes, I hear a yes over here. We'll go with yes. So we have a ton of crappy data for ACC, but whatever, and we're going to use it, and it shows that lymph nodes do matter. Adjuvant therapy, we'll talk about a little bit, mitotaine and radiotherapy, and then surveillance after you guys have removed the masses. All right, surgical management, it's really important to get complete resection. There's 3 for ACC, there's R0, R1, and R2. You guys use the R here, I assume, for margins. R0 is complete, R1 is microscopic, R2 is like the surgeon's like, oh shit, I left something. So you should just grossly know you left something, that's R2. Open surgery standard approach, we'll get into that a little bit. Lymphadenectomy standard for clinically negative and clinically positive nodes, definitely clinically positive. And then this is kind of funny, and we may fall into this category, but about 2/3 of adrenal surgeries are done at centers that don't do that many of them. So it's important for us, if we're not going to do a lot of them, to at least know the standards and live up to those standards. All right, so effective resections at margin survival. I'm not going to get into it too much, but I want to show you guys some of the best data that's out there. So this is just a simple Kaplan-Meier curve from 2016 looking at R0 versus R1. And obviously the R0s do much better. What you'll see when you look at this paper closer is the R1 patients tended to be a little bit more aggressive. So if stage is probably driving some of this, makes sense if we couldn't get all the tumor out. That being said, we definitely know the R0 patients have the best chance. And something that I was taught, and I'll tell you guys, in ACC, your best chance is the first chance. So don't mess up the first chance. Don't get in there and try to be cute and leave tumor behind, because you've really done a disservice to that patient, either laparoscopically or even open. So laparoscopic versus open approaches. There's a ton of literature out there. I think that this is probably the most salient I can be with it in terms of like looking at which studies. But this top study was really done with expert surgeons, really great surgeons. 110 open cases versus 46. They were essentially, it's retrospective, but they kind of would just do it based on surgeon preference and patient kind of characteristics. What we saw was in the open cases, they had larger tumors and higher stage tumors. So that just means the surgeons were probably correctly picking the patients for open versus laparoscopic. But even with that, what we saw is the R1 rate was significantly higher in our laparoscopic groups, and this is pretty consistent across many studies. Capsule perforation is the big one. So the problem with laparoscopy and ACC is capsule perforation. And so a lot of us, when we're doing lap surgeries, we do a lot of tensioning and we do a lot of pushing away or pulling on things. And we just don't have that ability to kind of dissect the tissue away from the tumor. We tend to like push on the tumor. I know we do it in urology a lot more when we're minimally invasive. And so that capsule perforation looked at by the pathologist, they can see that in 20% of these cases on the lap cases. Only found it on, or only on 2% of their opens. So that ability again to be more gentle with the capsule, and the ACC capsules are super thin, and that's why it matters. And then the recurrence-free survival median months was much longer in the open group. So despite larger tumors, despite higher stage, they still did better with open surgery. And this is in expert hands. The other thing, and this has to do with capsule perforation, is peritoneal carcinomatosis is a real issue in ACC, and that rate is like 3 times higher if you've had laparoscopic versus open resection. That probably has to do with the pneumo with a capsule perforation and those things. So I think this is real. I think until we get better evidence that laparoscopic surgery is safe in this space, you guys should be doing these open. There's one other cancer that's a lot like this. The 2018, 2019 New England Journal of Medicine brought out a kind of total like practice shifting paper. Do you guys know what cancer that was? That like minimally invasive surgery did significantly worse. It's cervical. So in the OB-GYN literature, they were doing robot versus open hysterectomies for cervical, and like the recurrence risk was like 8 times higher in the robot group. So most centers don't even allow minimally invasive surgery for cervical cancer anymore. I don't know what we do here, so sorry if they'd still do that. But anyways, you shouldn't. So it's not just ACC. So there are some cancers that just, they're uniquely not great for pneumoperitoneum. So effective lymphadenectomy, I didn't want to get into it too much, but I want to at least show you some of the crappy data that's out there. It all looks like this. Essentially the retrospective reviews of, hey, did we do lymph nodes or not? And when we did lymph nodes, whether they were clinically negative or clinically positive, and whether they were pathologically negative or pathologically positive, they always do better. And so it's consistent amongst study after study after study that there's a therapeutic and not just a prognostic benefit to doing lymph nodes. Now, where the heck are the lymph nodes when you're doing an adrenal gland? Like, where are these lymph nodes? Where are you going to get them?
Around the renal vasculature and order.
Yeah, kind of, that's what we pick out. Doesn't make a lot of sense to me. Like it should go north, right? So really we should be getting retrocrural nodes. I don't know that, like I do that a little bit in testis cancer, but I don't do that very often. So it's like, I get that this happens. And when you look at these papers, that's exactly what they're doing. They're taking renal hilar nodes and periaortic and pericable nodes. But like, I don't know, it doesn't inherently make sense to me, but that is what you're going after. So if it comes up on the boards or whatever, and you're like, they tell you to describe what lymph nodes you're going to take, those are the ones you're taking, perihilar and pericable or periaortic. And you can just throw in retrocrural just to be awesome and be like, and we get the retrocrural nodes. All right, adjuvant therapy. So mitotain and radiotherapy are the 2 big ones, and we'll try to get through this as quickly as possible because it's kind of boring for surgeons. But mitotain is essentially this thing that's been around forever that basically stops cholesterol being converted into multiple different kind of downstream steroids and cortisol and such. And so it blocks 11 beta hydroxylase so that you can't turn cortisol into get it into the pathway here, and then stops you from making cortisol. So you'll see you're going to get a testosterone overload when you're on mitotain because that's going to be preferentially like built over cortisol and aldosterone. So everyone on mitotain essentially will grow hair where they don't want it. So men will like it, women will hate it. And then cortisol will be low. So most of these patients are on lifelong cortisol replacement, or at least in the short term, but a lot of them for long term because this effect lasts a long time. Aldosterone replacement's usually not necessary, but again, you're going to use endocrinology to help you through this stuff. And honestly, if they're getting mitotane, it's probably medical oncology. But I at least think you guys should know about what it does, how it works. So does it work? Well, this is the study that everything is based on for adjuvant mitotane. It was published in 2003 originally, and then re-updated in 2007 in New England Journal of Medicine. And it's a crappy study that they tried to make look good, but it's 3 centers. One of the centers did mitotane on everybody. One center or 2 other centers didn't do it on anyone. So if you were R0 localized disease, so complete resection, localized disease, one center gave everybody mitotane, and another center gave nobody mitotane, and another center nobody mitotane. So there's 2 control groups and then 1 treatment group. And essentially what they found in a retrospective analysis of these centers is that center that did the mitotane group did much better than the other 2 centers for recurrence-free survival. Now, that doesn't bear out as much in overall survival. You see those curves start to come together. But I think an important thing about any kind of study is looking at how the studies are made and then how the statistics are coming together. And what you'll see is this down here, the number at risks. So when you're looking at Kaplan-Meier curves, you should always look at these, number at risks. So number at risks at the bottom, you'll see that the number of patients at risk as this curve goes out get really small about right here. So this is probably your real effect long-term. So your long-term effect is right here. But over here on your overall survival, you guys will see the same thing where right here, all of a sudden I don't have very many patients. So if you come up here, you'll see that there's a pretty good divide amongst these curves in overall survival, which we lose when the numbers get really small. So I don't want to overemphasize the fact the end of the curves start to come together. I think the important thing is when my patients were at risk, that overall survival was pretty well separated. Does that make sense? Okay. So statistics are kind of hard, and we just look at these curves and it can be hard. But anyway, so that's what mitotane's based on. Essentially that crappy study, it's been kind of remade 100 different ways now. It always kind of bears out the same thing. It's never been done prospectively or randomized. Just honestly, there aren't enough patients. It's really hard to build a study like that in this space. Adjuvant radiotherapy. This is a little bit of a controversial space when to use it. We have a few different studies of single centers where really they're excellent cancer centers, and they've basically looked at whether it matters or not for R1 disease or high risk disease giving radiotherapy after surgery, and they don't see a lot of difference. In a very controlled center where they can kind of make sure that patients are getting what they're supposed to get, they don't see a huge difference. That being said, a lot of the radiation oncologists now have created this kind of retrospective matched cohorts where there as a center, they do it to everyone. And then they try to they go to like SEER data and make a matched version of what they did that didn't get radiotherapy. You guys know what I'm talking about, propensity matching. So then they compare and they're like, oh, look, our patients did a ton better. But that's a really crappy way to design a study. That being said, that's what they're doing because again, the numbers are low. And then NCDB studies are universally flawed, but basically they just went in there and said, hey, who got radiotherapy for localized ACC? Who didn't get radiotherapy? We'll compare them. And when they compare them, the patients that get radiotherapy do better. So basically, we don't have any good evidence. It might be helpful in the right setting. And so I think it's something to consider, especially if you think you have an R1 margin, it's probably worth it. Again, a lot of times these are young patients and they just get one chance. So suggested surveillance postoperatively, I think it doesn't, I don't know how much surveillance matters for for ACC, because if it comes back, it's essentially terminal. You can try to cut it out or try to like do directed radiotherapy or try something, but you know, this is the recommendation to do it every 3 months for the first 2 years, every 6 months for a couple years after that. But I'll say that finding it earlier, I don't think it matters too much, if that makes sense. Chest CTs and chest CT of the abdomen or MRI of the abdomen, whatever you want or the patient's preferences. Sometimes if they've had a nephrectomy, you'll do MRI because it's easier for not getting contrast load. And then you shouldn't really do hormone biomarkers unless it was functional pre. You don't need to keep doing that afterwards. So this is kind of the breakdown. This is how I look at it. I think this is a good summary of kind of all the data that's out there, all the guidelines that are out there. I think it's a little bit more nuanced than this, but I think this is a good summary slide for what you guys should take home from kind of the surgical side and where you go. So you do the open adrenalectomy. If you get R0, R1, or R2, R2 I put referral. That means if you got an R2, you should refer that patient somewhere else. You should probably also never do these surgeries again, because you should have known that going in, that you were going to be in that kind of a shit show. Okay. And you might have hurt that patient. So that's my own little warning to you guys. If I get a referral from you, I won't be happy. No, I'm kidding. So if you are on the other end of it and someone else has gotten an R2 and now you're getting that patient to see you in clinic, you should consider redoing surgery if you're comfortable, or sending it on to somebody else that's comfortable. Trying to see if they can get the rest of it out. I think the more important space for you guys to think about is the R0 and R1 space. R0, man, it's basically like stage 1 through 3. And if they have low mitotic activity, it's observation versus myodetain. So I do have nuance within that. So if you're stage 3, you have peri-adrenal fat invasion, or you have a node positive, you're getting myodetain. Like, I'm not putting you in the OBS group. I'm going to give you a chance there. In fact, I might just push on radiotherapy too. But again, it's more nuanced than this, but it's something to think about. If they have high mitotic activity, they definitely should get myodetain, and then plus or minus chemo. So you'll work with your med onc on that. I didn't get into the chemo regimens today. I'm happy to talk about that if you want to, but I didn't want to get into it too much. And then if you have R1, you definitely need adjuvant therapy on top of that. So myodetain, I would not only consider radiotherapy in a young, healthy patient, otherwise I would give them radiotherapy, give them a chance to win. And then again, mitotic activity breaks you into whether or not you should get chemotherapy in addition, okay? Right now they're doing like multi-institutional studies where they're trying to, they call them the impact studies. They're trying to take like 25 centers, and every time they get one of these patients, they try to randomize them based on kind of these features and randomize them to different categories. They thought it would take them like 10 or 15 years. It's already been like 25 years. They just, like, the data just can't come fast enough for us. So I wish it was better. I wish it was more clear, but this is just kind of where we're at right now. And you can always like email a friend or refer if you guys are uncomfortable after you do the resection. All right, so conclusion, workup of adrenal incidentalomas we talked about, clinical biochemical and radiographic phenotype. Localized ACC should be treated with open adrenalectomy, do a lymph node dissection, then risk stratify for adjuvant therapies, okay? First chance is the best chance, so do it right the first time, don't be cute. And then effective treatment for ACC requires a multidisciplinary team, which I think I pressed on you guys. You need endocrine, you need med onc, you should have rad onc. If you're in a small center and you don't really have a team of that stuff, I wouldn't take it on, because you may be jeopardizing that patient's like ability to beat it. So just be mindful of where you are and who your team is. So, all right, you guys. I took the full hour. I'm glad I took those slides out. Questions, concerns, comments?
You're talking about the laparoscopic versus open.
Yeah.
Laparoscopic have worse outcomes. Do you know for sure the mechanism, or has it been proven, or is it just theorized?
It's all theory. It's all theory. I think it's capsule perforation when you look at the studies, because there are a couple of studies that really show like LAP did no worse. Like really, they did great. And like centers like we have some just really good endourologists that are just really great laparoscopically, and they're like, oh, I can push the stuff away from the tumor, and they probably can. And so they've shown that they have pretty good outcomes, at least in tumors smaller than 5. So they're smart not to take on bigger tumors laparoscopically. And what they show is that the capsule perforation rate was way more consistent with open. So I think there is some technical expertise that goes into that capsule perforation. So you have to be mindful of your abilities. I think for most of us, if we're not doing a lot of this and we're not just doing 6 lap cases every day all the time, like it's hard to replicate that. It was more of like, I feel like it's a gorilla pounding on the chest moment for some of the lap guys to be like, look, we can do just as good as open. What are you talking about? But I don't think most of us can replicate that.
I just think it's really interesting, especially with the cervical cancer. Like, how does that differ? Or how does, we don't really do cervical cancer exams in
Yeah.
our area, but how, like, is there a common theme between the two that's leading to worse outcomes? Similar to that versus just the technique of the surgery, like, is there something else inherent to it?
So it's really interesting. So that New England Journal of Medicine article that was about the cervical stuff, one of the subsets was that it was the MD Anderson subset, like they were part of that and they were randomizing. And they really, when they first saw the group data, were like, well, this can't be real. So they went and looked at their own data. They're like, well, we do tons of both. And we feel like we have surgical expertise. And even in that center, the data was significantly skewed. And their theory is that there's something about cervical cancer and its exposure to the pneumoperitoneum that it biologically has the ability to land. And a lot of tumors don't. A lot of tumors, like, it gets in our pneumo, but they can't land and seed themselves. But they think that cervical probably can biologically, but they don't really know. Yeah, it's a good question. But that's why we need to study these things. I think the push towards, like, minimally invasive is awesome. It's been so good for our patients, but we really do need to be making sure it's safe, especially in rare tumors that we don't have the volume to really see it.